Hello and welcome everyone for tonight's EAO Just Ask. Welcome everyone all around the world. Tonight we have an amazing topic and an amazing expert. We have Professor Pascal Valentini, and Pascal, I have to say, I think you are a little bit a fan of the Just Ask. You are also a listener of many of these Just Ask, always asking many questions. So I hope that a lot of the listeners will also pump you with questions. You are world known as an expert, as an implant surgeon. You're the program director of the implant program of the University of Corsica. You have your private office in Paris. You are lecturing worldwide. You're one of the top experts to actually our topic. And you were the president of the EAO from 2012 to 2014. Pascal, it's just an amazing honor that you accepted our invitation, in particular, I think, to your favorite topic. Please, everyone, welcome Professor Pascal Valentini for tonight's Just Ask. Pascal.
Thank you so much, Stefan, for the nice introduction. You know, it's a really an honor for me to be part of this EAO event. You know, I have a long story with EAO, and it is always a pleasure to participate in EAO events. And today we will have the opportunity to discuss, as you say, my favorite topic. I mean, sinus lifts.
Absolutely. And we're so much looking forward to them. We already had the topic of external sinus lift with your long-term friend Tiziana Testori. Also, if you want to watch that, go to YouTube and watch that one. Pascal, I knew I'm going to have you as an expert. And I did some month ago, I did a case. I already know you're going to do this Just Ask with me. I had a small amount of residual bone. You see the clinical picture here with the radiograph from the baseline. I did an internal sinus lift. I didn't dare to do the internal sinus lift on the first molar, so I placed the immediate implant on the 4. I did an internal sinus lift on the 5. And then at the final reconstruction, I cantilevered the first molar. So what does the true expert of sinus lifting say? Should I have done a lateral one? Should I have used short implants? Or was it not too bad, my approach? What do you say?
What about the implant in position number 4? What is the available bone in that location?
I extracted this tooth. I think I had, like I say, 7 millimeters of residual bone, a little small internal sinus lift.
Okay. And why didn't you place an implant on this number 6?
Because I didn't dare to do it internally.
Yeah. What was the remaining bone height in position 6?
I think maybe 3.
3?
Yeah.
Okay. So that's a good option, but you know, I'm a little bit, I'm not a fan with distal cantilevers.
Yeah.
And that's the reason why maybe another option would have been to place a short implant or 7 implant, even penetrating a little bit in the sinus,
yeah,
without any grafting material, and a lateral approach on the number 6. That would have been my preference. But of course, it's a good option also, but it depends the patient, you know, also the occlusal conditions, all those things. I don't know your patient. Maybe it's a good, yeah, it's a good choice. Good choice.
Pascal, I feel that you want to be nice to me, but you would have done a lateral approach. Let's make it clear. You are totally right. Pascal, I know you have a lot of content for us, and everyone wants to hear your work and your research. The people from Sweden, from Turkey, from Portugal, all around the world, they're logging in. They want to hear your content. We know you have a lot of content, but it's a little bit the tradition of this Just Ask that we discuss. Everyone, please type in your question. Pascal is more than happy to answer your question, because we also answer always your question, Pascal, when you are one of the listeners. Pascal, get going. We look forward to your work.
Thank you. So today, thanks to the new technologies, advances, there are some questions emerging. I mean, today, thanks to the osseointensification, for example, is is it possible to use the crestal approach, whatever the residual bone height, especially when this parameter is less than 4 millimeter, and of course, making the um, lateral approach a little bit obsolete. In other words, today or in the past, this was the approach according to the remaining bone height, lateral or crestal when we had in between 4 and 6, and eventually more than 6 short implants. So today the question is it possible to go to this concept? In order to answer this question, maybe we have to answer three more questions. First, can primary stability be achieved even if RBH is less than 4? It is interesting to look at this cadaver study. It is more than 10 years old, but it is very interesting. And they checked the primary stability when RBH was in between 2 and 6 on frozen cadavers. And they saw that the only parameter which is strongly correlated with the primary stability is bone density. No more correlation in between bone height and implant diameter in order to get the primary stability. So this is very, very interesting thing. I mean, we have to focus on improving bone density in order to get primary stability, whatever the residual bone height. So how can we improve bone quality? By using, for example, osteotomes, by customizing the drilling according to the bone density. I mean, when we have type 4 bone, of course, we have to underdrill, what we have to undersize the drilling. Maybe we can use piezo or finally osteodensification. If we look at the literature, osteodensification is very good, even if we have a very limited RBH, as you can see here, less than 4. We have an excellent primary and secondary stability, but the follow-up is very short. It's only 6 millimeter. Same thing when we compare the osteodensification versus the lateral window, same thing. We have an excellent primary and secondary stability, I mean, after 6 months, but the follow-up is also very short in this study. So if we have to make sustainable the stability. So what is the effect of condensing bone in order to improve bone density on the long term? If we look at those two papers evaluating the implant survival rate when we have a limited RBH, less than 4, you can see that the implant survival is decreasing after 5 years. And it is much better when RBH is more than 4. Why? Maybe this bone condensation could be deleterious for the bone quality and osseointegration. Actually, if we look at this study by Wang on rats, you can see that if we compare conventional drilling with condensed bone, I mean using osteotome, we can create here some bone necrosis and we can increase the osteoclastic activity, leading maybe I say, to the some loss of osseointegration or some bone loss over time. And this study was confirmed more recently by Benjamin Koyak on the same model, I mean, on rats.
Pascal, can I have a
So,
quick question because it's so
yeah, yeah.
interesting? Does that only account for osteotome techniques, probably osteotomes with a tapered design, which are condensing the area, or does that also account for osteotomes with a parallel design? Might make a difference, right?
I think that usually in order we have to when we want to improve the stability, of course, we have to choose some conical drilling,
Mm.
or maybe they when the implant site is conical, maybe we will improve the stability. So I think it's much better to use conical osteotomes to
Mhm.
improve the stability. Okay.
Get it. Mhm.
And now look at the osteodensification. Here they compare conventional drilling with osteodensification type for bone on chips. And of course, it was excellent. And they had very good results. Same thing on dogs. But the problem is they checked the osteodensification only on type for bone. And sometimes we have to consider also the effect of osteodensification with cortical bone, because in some cases, and you can see on this drawing, we have cortical bone here, and above it we have the cancellous bone. And if we look at the results of this study, we have a perfect site for the implant here, but in that study they did not consider the effect of ossification on crestal bone. And this is the big problem, okay? Because if we go to the live patient, you can see here we have some different bone densities with a reduced RBH. You can see that the result, of course, will not be the same using osteodensification in those different situations, because we have some cortical bone and we do not know the outcome of osteodensification with cortical bone. We don't have any data in the literature. If we look at human cases, you can see here on situation when we have uh, high bone density, you can see we can get some failures using also osteodensification. That it's really this is really a question mark regarding this technique.
Pascal, just a clinical question.
Yeah.
How should I check the density? Because if I have a small amount of residual bone, like 4 millimeters, it's very difficult to check the density in this 3 to 4 millimeter of drilling. Get my point?
It is very difficult. You are perfectly right. But we have the opportunity eventually to use Hounsfield unities. I mean, the analysis with the starting from the CBCT, we can have an idea.
Yeah.
And also, when we start the drilling. And I think that starting the drilling, we can feel the bone density. Okay.
Good.
And it is really, really important to determine the density, because we have to be ready to change the technique in case the density is not very good for the densification.
Yeah.
I think that it is the only thing we have to be able to change scenario and to change the technique according to the bone density we feel at the time we start the drilling.
Perfect. Thanks.
Now, if we look at this paper coming from Alberto Mache and Joe Can, they conclude their paper telling that the thing we have to consider is the corticocancellous ratio, because the higher the density, the higher the risk of compression necrosis. And this is really an issue. And also, in other studies, they show that the higher the insertion torque, I mean the primary stability, the higher the risk of osteocyte necrosis, leading to an increased marginal bone loss. And in that paper, also coming from Belgium, you can see that in case cancellous bone is less than 40%, the 3 years marginal bone loss is 3 times higher compared to the when we have more than 60% of cancerous bone. So it is very, very important to consider this ratio before choosing the technique. Okay. And of course, if we have some marginal bone loss, which is increased, we will have some, of course, some long-term biological complication, for example, periimplantitis.
I mean, Pascal, maybe also if you would have a harder bone, there may not be a need to condense it so much because you can anchor your implant easier, right?
Exactly, exactly. But that's the reason why you have to change the technique.
Yeah,
If we have dense bone, if you want to use the crestal approach, you have to drill normally.
right.
You don't have to customize to under drill. This is very important.
I think that's a good point. I think you should not always condense. You should make it depending on as you normally do with an implant.
Absolutely. You
Yeah,
have to customize
yeah,
the approach according to the bone density. This is very, very important.
got it.
We have to be able to change the technique. In those studies where they studied they checked the long-term marginal bone loss for osseodensification or osseodensification versus conventional drilling, you can see that the bone loss is increasing over time. The more you wait, the more you have the uh, bone loss. But the problem is in that study, they they stay to only very short or with sorry with a short-term follow-up. And you can see here, for example, here in this the Valerie study, they checked at 3, 6, and 12 months, and they saw an increasing bone loss over time. And this is really an issue. Now, to stay with the osteodensification, if we go to this multi-center study, which is the only one which was published um, with 5 years follow-up, it is the one by Salah Weiss, and this is a multi-center study. They have 3 centers. They have used different biomaterials. In here, RBH is in between 2 and 10 millimeters. But the interesting thing is to look at the stratification of the cases. I mean, they had 8 failures after not 5 years, but only 3 years in average. But if you look here at at the stratification of RBH versus the number of implants, you can see that more than 80% of the cases have been done with more than 4 millimeter. And we do not have any information regarding the correlation in between the failures and the bone height. And we do not know also if we had early or late failure. It would have been interesting to know if we had failure in that situation, I mean 2 to 3, or in other categories. And we do not have any informations. So bone loss is the long-term bone loss is really the key point, because when we have a limited bone below the sinus, you can see that the bone resorption can lead to the absence of the native bone. So that's the reason why, in order to make the osseointegration sustainable, we have to graft this area. Of course, in order to make the osseointegration sustainable for a long term, we have to get bone here. So the question is now, is the bone we get here live bone, and it will be it will be able to provide us with good osseointegration for a long term. If we look at this paper where they compared the use of osseodensification with or without grafting material, they have an excellent implant survival rate, but the follow-up is only 6 months. And this is an issue. If we look at other papers where they checked the long-term survival when RBH is less than 4 millimeter, unfortunately, all the available papers are with the osteotome technique. You can see that the um, they use, sorry, in that those studies they use graft material versus no graft material. And if we look at the results, you can see that the implant survival rate is decreasing when we have RBH less than 4, but also you can see that, for example, here in the Ramelsberg study, the implant survival is decreasing from 87 to 78 after 10 years. From 5 years, it was 87, and it is only 78 after 10 years. And you can see that there are no differences when we are using grafting material or we do not use any grafting material.
Pascal, there's a question from one of our listeners. Ali Savas is asking exactly that question. What is your opinion? When should we do internal sinus lift with grafting or without grafting? Now you showed the data that there's no difference. What is your personal take?
It depends the remaining bone height. If we have a limited bone height and we expect some marginal bone loss over time on the long term, we have to stabilize the implant with new bone. That's the reason why we need graft. And maybe there is a point to be clarified. We know that eventually we can have spontaneous bone formation when the sinus is narrow, but it is not the case when the sinus is wide. So this is very important, you know. Maybe in case the sinus is narrow, there is no need to use a grafting material, but it is important to use the right grafting material, not all the biomaterial, the right biomaterial to be sure we're going to get some live bone inside the sinus.
I think that's a great answer. Thanks for that, for Ali. Just check also the wideness of the sinus. It's important.
Exactly.
The more narrow it is when you internally sinus lifted, you may are able to avoid a grafting, right?
Exactly.
Great.
So now, if we are sometimes when we are using, but most of the time, it is recommended to use biomaterial. I mean, osteoconductive material. And if we have some perforations, of course, we can get some very serious complications as acute sinusitis, for example, that you can see on those images. So now, how can we predict the risk of perforation? We know that there are no correlation in between the thickness of the membrane and the risk of perforation. Of course, a thin membrane can be torn, but also a thick one, as you can see on this graph. Okay, the more predictable thickness for the perforation is when we have in between 1.5 and 2 millimeter in thickness. But what about now? What about the influence of the sinus width on the incidence of perforation. You can see here on the left, when we are performing the lateral approach, when the sinus is narrow compared to the sinus, the wide sinus, the implant, the incidence of perforation is higher for narrow sinuses compared to the wide one. But it is exactly the opposite for the crestal approach, according to this paper from Claudio Stacchi. You can see here when the sinus is narrow, the Hall ratio is 1, and when the sinus is more than 12 millimeter in width, the Hall ratio is 16 times higher.
So
So that
Pascal, I mean, that could have also been a factor I should have considered in my case, right? In the very beginning.
exactly, exactly,
If it was a narrow sinus, I could have done maybe an internal sinus lift with a residual amount of 3 millimeters. If it's a
e-
broad sinus, I should do a lateral, right?
exactly. That's exactly the reason why I told you I made this comment on your clinical
You
case.
see, I learned something, Pascal.
Thank you. Thank So now, what about the influence of the perforation according to the bone gain we expect? When the LBH is limited, we need to get more bone to stabilize the implant. And in that study, they elevated the membrane 6 millimeter versus 3 millimeter. And you can see that the higher the elevation of the membrane, the higher, of course, the incidence of perforation. So in case we have less than 4, we will need more bone. We will have to elevate the membrane higher. And of course, the risk of perforation will be much higher compared to the cases where we use the crestal when we have more than 4. In that paper, coming from my friend Ziv Mazor, you can see that they checked the perforation rate using osseodensification and, of course, with grafting material. You can see that for when LVH is less than 5, they have 22% of perforations. Those perforation has been detected using the Valsalva maneuver. But we know that this maneuver is not predictable to diagnose the perforation. And of course, I'm sure they had some undetected perforation because they do not provide us with the implant survival rate. So the other question is now, when does the perforation occur? For this, we have to look at this cadaver study coming from Loma Linda in 2012. They compare 3 different approaches with the crestal approach with an endoscopic control on fresh cadavers. And you can see that here you can have a perforation when you manage the membrane, you handle the membrane, but also at the time you place the grafting material. And if we look at the results, only 10% of the perforation they occur at the time of the membrane detachment, and the vast majority, I mean 30% and 60% afterwards. I mean at the time of the grafting material is inserted, and 60% of perforation they occur at the time of the implant placement.
Which is a huge problem, Pascal, because then it's
Absolutely.
undetected.
The only way to detect them is to use an endoscopic
Yeah,
control at the same time you perform the surgery.
yeah.
We had exactly the same, but the same results using in the same university. 2 years ago, we had the opportunity to carry out a cadaver study. You can see here comparing the osteotomy approach and the osteodensification on fresh cadavers also. And you can see that here they had The incidence of perforation was 40% with the control, I mean osteotome, and 50% with the osteodensification. And most of the perforation with osteodensification, they occurred at the time of implant placement.
And can you compare the Schneiderian membrane with the cadavers with a life setting?
Yeah, of course. We have papers like this on that topic showing that it depends, the mechanical properties of the membrane depends on the way you freeze the cadavers.
Mm.
If you are using a quick freezing technique using liquid nitrogen, you will preserve mechanical properties of the membrane. If you wait too much time, of course, the cadavers, the mechanical properties will decrease, and of course, the result, they will be much more fragile. The
Got
membrane will
it.
be fragile.
Got it.
Okay?
Mm.
And here we have the opportunity to, I had the opportunity to get those live surgeries on patients, not on cadavers, live patients. You can see here on this very wonderful video coming from India, from my friend Yazad Gandhi. You can see here some grafting material going across the membrane. You can see here, this is the Snyder membrane. And even if we are using a putty material, you can have some granule loss through the membrane. Same thing with osteodensification and an allograft here. You can see some granules, they go across the membrane. So, is the bone we place here vital bone? That's the problem. If we look at we have only one study providing us with some histologies. And you can see on this study by Claudio Stacchi, again, you can see that when the sinus is narrow, we can expect a very good bone formation. You can see here on the left. But when the sinus is wide, you can see that the percentage of vital bone is around 3%. Are those 3% able to provide us with a long-term osseointegration? I don't know. So what is the best material in your opinion to induce bone formation? Because we have no evidence to say that for with biomaterials we have a very good bone formation. So what is the best material? Maybe it is this one. I mean, PRF, because even if we tear the membrane, we can expect some very good healing using PRF as grafting material for the membrane. And we don't care in case some PRF material is going through the membrane into the sinus. Okay? And the other advantage is this one. Within the sinus membrane, you can see here, this is the sinus floor. We place some, and above, this is the membrane. In between, you have some PRF. And thanks to this PRF, you can induce, and the growth factors which are contained in the PRF, you can induce some mesenchymal cells differentiation, which are contained into the sinus membrane, and those cells, they can be transformed in osteoblasts thanks to the induction produced by the growth factors. Because within the sinus membrane, you have target cells for grafting material, for PRF, but not for the biomaterial. Biomaterial is not able to trigger bone formation starting from the bones, the mesenchymal cells contained in the sinus membrane. The biomaterial, they can induce bone formation using osteoconduction. I mean, the cells, they come from the the pristine bone and not from the uh, sinus membrane.
Pascal, there's also a question from a listener from Gabi coming to that topic. In case of a perforation, I mean, you now advocated PRF. What about a BIOS collagen, for example, or something with a little bit more sticky and collagen? What do you think about that?
The problem is not, the problem is not really the perforation, because the perforation will be detrimental when you are using um, mineralized uh, biomaterial, okay? Whatever the form. I mean, even if you mix uh, mineralized material with collagen, we have studies on rabbits showing that if you place this material, I mean, HA plus collagen versus only HA, if you create perforation on the sinus membrane of rabbits, in both cases, you're going to get some granule loss.
Mm.
It is impossible to, we don't have a lot of papers on this topic, but we have only this one, but we don't have any evidence to say that we can prevent granule loss through through an undetected perforation using mineralized material
Yeah.
mixed with a collagen.
And then you get most of the complications by this.
Exactly,
Yeah,
exactly.
got it. Okay.
So, what is the technique we are using? We can use this technique. I mean, we drill normally 1 millimeter away from the sinus floor. Then, using an osteotome, we can break the floor of the sinus. Then we insert some PRF, and then we place the implant. This is the technique we are using, and you can see here those cases. Even after 3-4 years, we have some bone formation and the good implant stability. And the efficacy of this material has been proved also in this review we published a few years ago, last year, sorry. You can see that we have a very good implant survival, 100%, using only PRF as relative material. But of course, the follow-up is very limited. It's only 1 year. We have only one paper from my friend Tiziano. You can see that after 5 years using this technique, you can have an implant survival which is more than 93%. And of course, without any complication. The last problem we have to answer is this one. We don't have any data regarding the use of crestal approach for multiple edentulous sites. And this is really an issue, and this is a priority for the future for the research. I mean, is it possible to manage two adjacent osteotomies in the same sinus without without any increasing increased perforation rate? And also, is it possible to stabilize the graft when performing two sites with the crestal approach? And of course, all those questions are unanswered today. So right now, in order to conclude, it is possible to achieve primary stability when LBH is less than 4. We have seen this because osteodensification is excellent, but also piezo, osteotomes, and undersized drilling. The problem is the membrane perforation. Whatever the technique, we have membrane perforation when LBH is decreasing. And the perforation occurs mostly after the membrane has been detached. I mean, at the time we place the graft and at the time we place the implant. And it is impossible to predict the risk of perforation looking only at the CBCT because we are not able to judge the mechanical properties of the membrane only looking at the CBCT. And of course, we know that the lower the RBH, the higher the need to elevate the membrane. And of course, we will have more perforation. Maybe for those cases, it is interesting to use short implants in order to limit the elevation of the membrane. And there is no evidence today of bone formation using an osteoconductive grafting material. It is impossible to say that this bone we get, it is really live bone because we don't have any histologies on live patients. And of course, we don't have any evidence for multiple implants using this approach. So today, the true revolution is not really technological, but it is more biological because we have to concentrate, we have to focus on trying to implement techniques which are providing us with live bone in order to make the osseointegration sustainable for a long term. What is a reliable technique? A reliable technique is a technique with clearly defined indications, which is well codified. I mean, we know exactly what time we have to do a specific thing. The technique has to be well documented, of course, with reproducible results. And we know all the risk factors for this technique, and also we are able to manage all the complications in an easy and predictable way. The only technique which is gathering all those requirements is this one. I mean, the lateral approach, which has been published for the first time 50 years ago by Il Tatum and then by Phil Boyne and Bob James from Romalinda. This technique is well documented. This is the oldest in the literature with more than 50 years of follow-up. And finally, if we refer to this global consensus conference, which was held in Boston, I think, last June, 1 year ago, gathering many experts from different countries. And this conference has been organized by EAO and different scientific societies all over the world. You can see that the experts, they conclude that for 85% of them, transcrestal must be performed when the RBH is in between 4 and 6, and less than this, we have to go to the lateral. I would like to take advantage of this lecture to invite you very shortly for the 30th anniversary of the implant program of the University of Corsica in Calvi next May 2015, and I'm looking forward to meet you, some of yours, of course, not all of yours, but some of yours in this very beautiful city. So thank you so much for your attention.
Pascal, that was amazing. I applaud you for your work, for your lecture. This was so eye-opening for me. I loved it. Thank you so much. It was really amazing, your work and also how you detected the details. So nice. Congratulations to your work. And I will check my schedule for Corsica in May. It should be beautiful, right?
You're welcome.
Pascal, there are a bunch of questions. I don't know if we can manage them all, but there will actually be a EAO Congress in Lisbon. I guess Pascal will be there. There's still an early bird rate to 6th of May, so register for the Congress. Also, Nelson Pinto is here. He's congratulating you. Hi, Nelson. There is one question which I found is very interesting. It is about the difference between osteodensification and internal sinus lift, like with the Summers technique or whatever. So what would be the clear indication scheme, or is that very difficult to say? So there's a question from Frosty Summer, your opinion about Densa burrs, and what is the indication scheme? When are you going for Densa? When you're going for osteotome mediated sinus lifting?
To be honest with you, in my opinion, there are no differences. And but if you look at the literature, but we do not have any evidence for this. Some people, they say that with osteotomes, you have much more chance to get bone necrosis compared to the osteodosification. The only problem is that we do not have any long-term data regarding the marginal bone loss with osteodosification. Maybe, I don't know, maybe we have less bone necrosis. I don't know. We don't have any evidence.
But why is where's the biologic rationale behind it? I mean, we're also compressing bone in a certain way.
You know why the compression is leading to bone resorption? Because the fracture of the cytoskeleton of osteocytes due to compression. So I don't know if we do not fracture the osteocyte skeleton using osteodosification.
That's my question. Does it not
I don't
happen with
know.
that technique?
Today, I don't know. We don't have any data in the literature providing any evidence on this specific point. We don't know.
Got it. Pascal, there's a question also. Michael Paya is here. He's congratulating you to your work. Hi, Michael. Now there's a question about hydrolytic or this osmotic sinus lifting. You probably heard of that, where you insert a balloon or water or whatever. What is your take on that?
The problem is always the same. Whatever the technique you are using, you can elevate the membrane and you can perforate or not the membrane. The problem is that the perforation is occurring after the moment you have moved your membrane up because of the pressure you apply on the membrane, because of the biomaterial and because of the implant placement. The crucial point is not at the moment you handle the membrane. It is afterwards.
Yeah.
So whatever the technique, it will be the same.
So maybe the best answer for Ali, because he's asking that a little bit, what is the best technique? Well, the best technique is the diagnosis before, is the residual bone height.
Exactly. You have to decide the technique you're going to use to stabilize the implant. As you said, when the remaining bone is cortical, is dense, there is no need to condense.
Yeah, very good point.
But there is a need to create vital bone because over time you're going to lose some bone for sure. And then if you don't have any bone above this resorb bone, you cannot maintain your osseointegration. So the secret is to create vital bone in order to compensate the marginal bone loss.
Yeah, I get it. There's one question from Alberto Salgado. Alberto, thank you, because I don't know if you're aware, we have published them 20 years ago with Hannes Wachtel together, a technique where we only fracture the sinus without friction on the walls. What do you think about that? That is a little bit more to parallel osteotomes, but I think we answered that. That's probably a situation where the bone is dense, right? Where we should not condense.
There is another technique which is maybe much more predictable to break the sinus floor, is to break the sinus floor using an implant.
Mm,
And we have done some cases like this, and it is very predictable. You don't have the problem of paroxysmal vertigo using an osteotome. You can drill, you can go through the sinus floor using the implant, and then you remove the implant back, you place the PRF, and then you put the implant back
I
on
get
the
it.
on the
Does that
crest.
also work when you have a real cortical inner sinus wall, but does it not hit the cortical wall and stand there, the implant?
Or there is another technique. You can erode erode this bone
Yeah,
using piezo,
yeah,
as suggested by Tiziano.
yeah, yeah.
Tiziano is using PRF with piezo also.
Got it. There's another question. Now, this is a very broad question, but just maybe your 2 or 3 minutes on it. Phil is asking, what is the best material for lateral sinus lifting? Obviously, the same answer. It's not the material, it's probably the technique. But what is your take? I mean, are you mixing DBBM material with autologous bone? Just your 2 sentences. I think if you are interested in that, watch the Just Ask with Tiziano. We talked about this in detail. So what is your
No,
take?
it depends. It depends the degree of atrophy. Maybe when there is nothing, I would mix autogenous with DBBM, but most of the time, I think DBBM is enough, but the prerequisite to build the vital bone with the lateral, huh? We are talking about lateral, right?
Yeah, yeah, we're talking about lateral.
And the important thing is to manage the best and the largest contact in between the grafting material and the surrounding native bone. Because by doing this, we improve the osteoconduction. And it is the only way to have a very good bone quality. That's the reason why when we perform the lateral approach, we have to reach the medial wall, and we have to be able to compact to condense the grafting material against this medial wall, and also against the anterior wall, but mostly the medial. This is very important to get bone cells coming from the medial wall to colonize, to go and to 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 produce bone, which is um, deposited on the grafting material. It's a kind of scaffold. So it is very, very important to you will not get bone if you do not put the grafting material in the right position. I mean, in direct contact, in intimate contact with the native bone.
Yeah,
So
very
whenever
good
the
point.
material, the osteoconductive material, it will work.
Good
The
point. So
only
you need
problem,
to reach the medial wall to the nose, right? Yeah.
yeah, exactly.
Um, Very good point. There's one more question about the putty material. I think you answered that already for internal sinus lift. Is there any advantage of like a sticky material, putty material? You see anything? I mean, you already answered that there's no evidence.
No, no evidence. No.
Okay, got it. There's one more question which I like a lot about detection of perforation, which is obviously a problem. You talked about the Valsalva maneuver. Is maybe a soft irrigation with saline? Is that a good idea? But I mean,
Yeah,
you already said that most of the perforation that occur when you have placed the implant. So yeah,
no, it is impossible. For the crestal approach, the only moment you can detect the perforation is at the time you handle the membrane with different techniques, different tools, okay? But afterwards, it is impossible. The only way to detect is an endoscopic control for the crestal. For the lateral, of course, Valsalva is not really efficient. What we do in order to detect the perforation using the lateral, we inject some saline or sterile water, and we have the patient, if he feels some liquid in the nose.
Okay, got it. Pascal, it's amazing. There's still a lot of questions. We are running a little bit out of time. I have one very last question, which I always find a little bit difficult to decide clinically. Let's say I see a perforation during my instrumentation. Let's say I did an internal sinus lift, 6-7 millimeter residual height. I want to place an 8 millimeter implant, whatever. I see I get a perforation. Am I placing it or am I not placing it?
You can place it if you do not use any grafting material
That's my
or
point.
PRF. Don't, in that case, you should not use osteoconductive material, mineralized material.
But I can
Residual-
place it even if the implant sticks a millimeter or 2 millimeter out of the sinus.
Exactly.
Got it. Got it.
Exactly. Because now we know even if the implant is is protruding in the sinus, there are no issues.
Yeah.
No issues.
Pascal, that was amazing. I thank you so much that you did this with me. Everyone is applauding you. There are a lot of top shots, top experts who listened here. I know all these names. They applaud you to your work. I learned a lot. I would have done my case different. I would look at the narrowness or wideness of the sinus. Stupid on me, I didn't look at that. But now I know. Pascal, with this, I would like to thank you also on behalf of the EAO. I would beg everyone to come to Lisbon, to come to your course in Corsica, of course. There's still an early bird rate. With this, Pascal, have a great night in Paris, drink a glass of red wine, and see you all soon, all around the world. Ciao, ciao, good night. Thank you again. It was a great pleasure.
Thank you so much. Thank you so much, Stefan.
Ciao, ciao, ciao.